Hello, my colleagues. This is Dr. Wes Ely. I am an intensivist and a health services researcher in the United States at Vanderbilt University. And I'm not using any slides today. I'm going to give you about a 5 to 10 minute talk about post-sepsis care with a focus specifically on the brain. Elsewhere in this chapter on post-sepsis care, you're hearing a lecture by Margaret Herridge, which is more generic in the post-intensive care syndrome area, where we know that the body is diseased after sepsis by acquiring a neck-down muscle and nerve disease. So I'm going to focus this talk on the science behind the neck-up component of what happens to the body during severe sepsis, during septic shock, and during the hospitalization. And then the person has to go out into the world and try and pick up the pieces of their life to become a functional human being, return to work, the matriarch and patriarch of their family, and carry on relationships. Why is it so difficult for somebody after sepsis to do this? Well, the brain is our CPU, our central processing unit of the body, and it needs, obviously, intense amount of food, oxygen, water to live. So perfusion during sepsis becomes a big problem, because sepsis obviously is a disease of inflammation and coagulopathy. During the sepsis course of your patients who you care for with sepsis, they have both a profound amount of inflammation, which is disrupting their endothelial lining of their blood vessels, large and capillary beds, and then also a thrombophilia, a love of clotting, which is creating microclotting. And this all disrupts the blood-brain barrier, creates inflammation, and a problem at the glial cell and the neuronal level. And when the glial cells are unhappy, their supportive structure that they give to the neurons leaves the neurons wanting for better support, and the neurons get diseased. So in the acute circumstance, when I, as an ICU physician, am caring for somebody at the bedside who is in septic shock with pneumonia, cholecystitis, pyelonephritis, whatever the cause may be, I am thinking very consciously of the fact that this person, their brain needs to be well perfused. I need to get the mean arterial pressure up. I need to take care of the source of the sepsis, to drain that abscess. I need to cover the antibiotics beautifully, to cover the organisms beautifully with antibiotics. If it's COVID-related sepsis, I'm thinking about how do I give the right antivirals, and in addition to that, the right immunomodulation. And immunomodulation is a very important word here, because I'm not thinking about immunosuppression, but modulating that immune system. We know that, for example, in COVID, steroids, baricitinib, tocilizumab, these immunomodulators help save lives, and that's a viral form of sepsis. Now we are dealing with the aftermath of COVID, which is a viral form of sepsis, in the brain dysfunction area. We know that millions and millions of long COVID patients after their form of sepsis have a brain dysfunction. Now, in 2013, we published a paper in the New England Journal of Medicine that outlined how severe is this brain dysfunction after critical illness, predominantly after sepsis. And in this paper, the New England Journal of Medicine 2013, called the Brain ICU Study, we showed that the brains of patients after critical illness, and again, predominantly this was sepsis, were operating at about the level, in about half of these patients, about the level of traumatic brain injury, TBI, or Alzheimer's disease. So how do we put this together? What had happened was that in this study of 800 patients, we found only 6% of these patients had any baseline cognitive disturbance, and yet as many as 50% of them had some form of brain dysfunction on the back end of sepsis. What we think has happened in this circumstance is that there has been a form of neuronal injury manifested acutely in the hospital as delirium. So the phenotype of this acute brain dysfunction is delirium, and that delirium is an independent predictor of the acquisition of this rapidly acquired dementia. I'm using two words there, delirium and dementia. Delirium being the acute form of brain dysfunction, the dementia being this long-term form of brain dysfunction, which prior to us defining this as a problem after sepsis, we thought of this as only a chronic disease, Alzheimer's disease, frontotemporal dementia, multi-infarct dementia. But now we know that millions of people around the world are having a rapidly acquired form of dementia after sepsis. And again, it's because we think that this inflammatory and coagulopathic disease is causing downstream problems at the neuronal and glial cell level, which create actual death of neural tissue. So I'll say that again, neuronal apoptosis is what we think is happening. We actually see on CT scans and MRIs that patients lose structure of their brain. They actually get an increased ventricle to brain ratio. The ventricle to brain ratio is a barometer of atrophy of the brain. So patients on their neuroimaging, whether it be CT scans or MRIs, are found to actually have atrophy after acute illness in the ICU. And delirium is a predictor of the acquisition of that atrophy. So on the back end of sepsis, one of the things that we as clinicians need to be aware of is that we should be preparing our patients for the awareness of and dealing with this form of acquired brain injury. And what I say to my patients is, Miss Smith, Mr. Jones, I want you to be aware that when you're back at home, you might find it difficult. Now I'm going to unpack for you the science of the neuropsychological deficits. You might find it difficult to remember people's names, to organize your life at work, to go on the computer, to go into social interactions at parties. It's going to be embarrassing for you if you don't remember people's names. And what's even more perhaps important is that you will have a difficult time with daily living tasks such as executive function. Executive function is our ability to organize ourselves in the tasks of our job or of completing a shopping list at the grocery store, at the hardware store. And this is because sepsis-induced long-term brain dysfunction, sepsis-acquired dementia, is first and foremost in two domains of neurocognitive deficits: memory and executive function. So your patients are going to have problems with memory and executive function that they need to be made aware of. And then what can we do about it? Well, two things. One, upstream from the illness in the ICU, we can do all that we can to try and prevent delirium. So we need to be evaluating our septic patients for delirium every single day using tools like the confusion assessment method for the ICU, the CAM-ICU. And then when patients are delirious, we need to be thinking about what can we do acutely to reduce the duration of their delirium, since every additional day of delirium increases the risk of long-term cognitive impairment by around 35%. Okay? So if every additional day increases the risk of cognitive impairment by 35% on the back end, then I need to reduce the duration of delirium. And I do that by exercising the Dr. Dre, a mnemonic, DDRE. That's diseases, drug removal, environment. DDRE, diseases, drug removal, environment. And the number one disease is sepsis. That's the disease we need to shorten the duration of, treat drain the abscess, get rid of the sources, the source control, and also treat with the right antibiotics, and then get rid of drugs that exacerbate the circumstance, like the wrong antibiotics, over-sedation, propofol overuse, benzodiazepine overuse, which is rampant during COVID, and even narcotic overuse, opioid overuse. These drugs are profoundly deliriogenic, and they contribute to this acquisition of brain dysfunction. And then E in the Dr. Dre's environment, that is things like hearing aids, eyeglasses, day-night cycles, sleep, restoration, and mobility. These are the things that we have to work very hard for our septic patients to get mobilized out of the bed, stop their sedation early, wake them up, and then deal with the sensory deprivation issues that people have if they have hearing or visual disturbances by giving them their eyeglasses and their hearing aids back. All of these things will help reduce the acute duration of delirium, which will then help reduce the amount of dementia on the back end. And then on the back end, there's going to be some degree of dementia acquisition, even if you do your best job in the ICU. And what we think needs to happen there is that the patients need to be allowed to go through some form of cognitive rehabilitation. Cognitive rehabilitation with computer games. We use computer rehab games like Evo, made by Achille. Posit Science makes a program called Brain HQ. These are computer games people can play on iPads, and they basically exercise their brain to try and improve their memory and their executive function. We're doing 3 ongoing randomized controlled trials right now of cognitive rehabilitation to try and test the dose and duration of these. But generally, we put people on 8 to 12 weeks of brain games, and that is found by many patients to help them get their memory back. We don't think people time out on this, so even months and years later, they can use these programs to try and rebuild their brain, much like you would rebuild your bicep. If your bicep was put in a cast and atrophied during 8 weeks of a cast to have a bone heal. So in summary, where are we? Sepsis is a disease of inflammation and coagulation. That creates problems at the neuronal and glial cell level at the brain. Patients get delirium. That is a predictor of the acquisition of a rapidly acquired dementia. We can treat that delirium by using the Dr. Dre, addressing diseases, drug removal, and environmental issues. On the back end of sepsis, we need to make patients aware of these problems so they will know that they're going to have memory and executive dysfunction problems, and they can be aware then with their family, and everybody can kind of chip in to help them out. But they can also exercise their brain with games like Scrabble, Sudoku, or even computer games to try and get their brain built back up again. I hope this has been helpful to you. My name is Dr. Wes Ely. You can find me on Twitter at WesElyMD. I'm here at the SIPS Center at Vanderbilt University in Nashville, Tennessee, and it's been my privilege to be with you today. Thanks.